Assalamualaikum warahmatullahi wabarakatuh and good morning. Thank you for having us today in breakfast at UMHealth during fasting month Ramadan. My name is Dr. Azmi Kadir. I'm Senior Consultant Neurointervention Radiologist, President for Malaysian Neurointervention Society and also Regional Core Committee for Society Vascular Intervention Mechanical Thrombectomy 2020. With me today is my fellow Dr. Wan Ibrahim bin Wan Azman. For the past few years, we managed to change Dr. Wan Ibrahim professional genetic from autosomal dominant interventional cardiologist into intervention neuroradiologist. Both of us and our team has made history for Malaysia. About a decade ago, we are the first center to perform uh, thrombectomy in this region, and Dr. Ibrahim also is the youngest doctors under supervision who can perform thrombectomy by himself. His topic today is about explore stroke direct to Angio. This concept is very important to improve stroke treatment because stroke treatment is time sensitive. And as you know, Universiti Malaya Medical Center is a comprehensive stroke center. Soon, when our Malaysian government and our stroke service is improving throughout the country and KL, we will get more patient and we can get from patient from satellite hospital can directly transfer to the angio room. I would like to say thank you very much for UMMC management led by our Prof. Nazira Hasnan as a director, dibantu kuat oleh Dr. Saleh, Prof. Azura, and mantan Prof. Zul, who early sent and convinced our Ministry of Education to have a angiogram in trauma center. Soon, at end of this year, maybe next year, we can perform emergency stroke thrombectomy itself in our emergency department, and also can perform PCI, cardiac related disease, and also vascular intervention by Dr. Haris. Without further delay, I would like to ask Dr. Ibrahim to give his lecture. Thank you.
Thank you, Prof. Khairul, very much for the kind introduction. Prof. Khairul is my mentor, and he supervised me a lot and teach me a lot. So today, I was given this topic to explore direct transfer to angiogram suite for acute ischemic stroke and improving outcomes. So we see these insights from the latest AngioCAT trial. Okay, this is my disclosure. Okay, very recently, we have a collaboration with the Global for Access for Stroke Management, Society of Vascular and Interventional Neurology, Mission Thrombectomy. Together, MINIS, this is our Neurointervention Society in Malaysia. We collaborate to send this letter to the Malaysian Ministry of Health. We send this letter to say that this is a very important treatment, stroke thrombectomy, because stroke is a leading cause of death and top 5 contributors to disability in Malaysia. So in 2015, we have this highly effective new treatment, safe treatment for stroke. We call it a mechanical thrombectomy. And this has become a standard of care the whole world. So, however, despite the standard of care, a system of care needs to be in place to optimize the success and ultimately the outcomes. So we see from this letter, stroke management in Malaysia costs estimately 2013 million annually due to both indirect and indirect costs, including loss of productivity due to prolonged rehab, temporary or lifelong disability. Although this treatment seems expensive in short term, but it will be cheaper in the long term. So I'm just going to play you the video. So this is a patient here. This is the circle Willis. We have clot here in the left M1 occlusion. This is the clot at the left M1. So we puncture the groin here, and then we put our long sheath and our catheter all the way from the groin up to the thorax and go to the carotid and all the way up to the MCA. So we pass our micro wire, engage with our micro catheter, and engage with our aspiration catheter. And then we connect it to the vacuum and we aspirate out this clot to achieve full recanalization of the MCA. So acute ischemic stroke is a leading cause of disability. And as we know, stroke kills more men and women compared to prostate and breast cancer. So it's among the leading cause of mortality. So stroke thrombectomy is a powerful treatment because the numbers needed to treat for mechanical thrombectomy to achieve MRS score 0 to 2 ranges from 2.5 to 8. So what is a numbers needed to treat? Numbers needed to treat is just a medical statistic. It is defined as the number of patients that you need to treat to prevent one additional bad outcome. So it means here you need to treat at least 3 patient stroke to prevent one bad outcome. So the ideal number of numbers needed to treat is 1, means you treat 1 patient, you prevent 1 bad outcome. So here, the lower the number means the better. So here we compare stroke thrombectomy versus myocardial infarction PCI. So for stroke thrombectomy, you just need to treat 3 patients to prevent 1 bad outcome. Otherwise, for the MI PCI, you need to treat 40 patients to prevent 1 bad outcome. So means stroke thrombectomy is the numbers needed to treat is significant. So as we know, time is brain. So it's important to timely intervene this stroke patient from the symptom onset to achieve the reperfusion. So we must develop a strategy to minimize treatment delay. So as we know, time is relative. Everyone have a different time. So for example, from Albert Einstein, he quote that when you sit with a nice girl for 2 hours, it seems like 2 minutes. But if you sit on a hot stove for 2 minutes, it seems like 2 hours. That's relativity. In brain also, our time is relative. If patient have a more collateral, the collateral is good. So the time of the brain is longer. Means we can treat this patient in a long period of time. But if the collateral is not good, so we have a very short window to treat this patient. So in this kind of patient, time is an essence. So just to clarify about the modified ranking scale MRS score. So 0 means no symptom. 1, patient have a mild symptom but no significant disability, able to carry out all usual activities. MRS score 2, slight disability, but able to look on affair without assistance. So what we want to achieve is MRS score 0, 1, and 2. When patient achieve MRS score 3, 4, 5, and 6, means it's already a bad outcome. So the good outcome is 0, 1, and 2. Means patient no need any help, no need any assistance. So that's why we come with this concept of direct transfer to Angio suite. So DTA. So this is a novel approach, means we bypass the conventional imaging workflow. Usually we do a CT scan. We send patient from emergency, send to CT, then we do CTA, and then go back to emergency department. So it take a longer time, but we try to bypass this so that we can save time. So it aims to reduce the in-hospital workflow time for endovascular treatment. Means patient from emergency direct sent to angiography suite, and we assess the patient there. Then we do a flat panel CT there, and then we can decide straight in angiography suite for endovascular treatment. So study overview, this study title is AngioCAT trial. A study design is prospective randomized clinical trial. And then the objective is to assess the effect of direct to angio on clinical outcome in large vessel occlusion stroke. So investigator initiated single center trial conducted from September 2018 to November 2022. And then there's a blinded assessment of primary outcome, which is the MRS score at 90 days by the independent evaluators. So the methods, the patient selection criteria, consecutive patient with acute stroke screen, N equals to 466, suspected LVO stroke within 6 hours of symptom. So this is very important. It's within 6 hours of symptom in this study. Means it is a golden hour window for stroke thrombectomy to be performed. So N equals to 174. So this is a randomization process, random assignment to direct to angio or conventional workflow, 1-to-1 ratio, and stratified by primary admission versus secondary transfer. And study interventions, direct to angio versus conventional workflow, direct to CT, imaging protocols, flat panel CT, means from the flat panel from the angiography machine, we can perform the CT versus CT or CTA angiography. Then outcome measures, primary outcome and secondary outcome. The primary outcome is 90 days MRS score, which we want to achieve 0, 1, and 2, which is a good outcome. So this is the AngioCAT trial flow diagram. So 466 patients assessed for eligibility. Then we see here, most of them is excluded. Almost 300 was excluded. What we see here, because of the primary admission at off hours, means it is difficult to do this flow during off hours because there is no radiographer standby, no staff nurse standby, no IR standby, no MLT standby. So basically, there's no one around during off hours to do this flow. So, and then lack of EMS pre-notification, angiography suite not available. And then from this exclusion, we have 174 patients, and then it randomized 1-to-1 ratio. 89 patients go to direct to angio, and 85% direct go to the CT scan. So from this 89 patients, 15 non-LVO excluded, non-large vessel occlusion excluded. We can detect intracranial hemorrhage, 8 patients from this direct to angio. And then 7 ischemic stroke. This is a stroke but without a large vessel occlusion. Okay. So this is the protocol step, direct transfer to angio versus a conventional workflow, the initial imaging, diagnostic angiogram, IV thrombolysis, if indicated, decision for endovascular treatment, and admission to stroke unit, intensive care unit. For direct to angiography suite, the flat panel CT is used to exclude intracranial hemorrhage or large ischemic lesions, which means a very low aspect score. So, and then we can do a direct angiogram, confirmation of large vessel occlusion, and immediately after the flat panel CT, we can give the intravenous thrombolysis treatment if needed, and then we can decide decision of a thrombectomy based on the flat panel CT findings and diagnostic angiogram and admitted patient to stroke unit. So versus the conventional workflow, patient from emergency sent to CT, and then we do a CT angiogram followed by CT perfusion if needed, and then endovascular treatment is decided based on the neuroimaging, and then IV thrombolysis is initiated immediately after the CT if needed, and then decision of endovascular treatment based on the neuroimaging finding from the CT and CTA. So here, this is the primary outcome. Primary outcome from this study. We compare here. This finding significantly improved functional independence for adults with acute ischemic stroke compared to direct to CT for usual imaging protocol. So we know that we want to achieve MRS, at least MRS score of 2, 0, 1 to 2. So this is the percent of patient in the treatment group. Here we see here, the MRS 2, 1 and 0 is higher percentage compared to the direct to CT patient. Okay. So the adjusted odds ratio for 1 point improvement of MRS score is 2.2. So what does it mean? Means if this patient go to direct to Angio, so the MRS score will improve for 1 point, 2.2 times. So this is the secondary endpoint of the study. So rate of endovascular thrombectomy direct to Angio is 100% for confirmed large vessel occlusion case. Compared to the conventional workflow, only 87%. Not all confirmed LVO, large vessel occlusion, underwent endovascular thrombectomy. Door to arterial puncture is only 18 minutes. Imagine 18 minutes. Door to arterial puncture, but conventional workflow is 42 minutes. And then door to reperfusion, 57 minutes for direct to angio and 84 minutes for conventional workflow. And rate of dramatic early recovery. What is dramatic early recovery? Means that immediately after the thrombectomy, patient regain full power. Okay, so for direct to angio is 33% and conventional workflow is 28%. And rate of MRS score of 2 or below at 90 days is 43%. 43%, almost half. Compared to conventional workflow, 27%. And it's very safe. The safety outcome is comparable between two groups. So interpretation of these findings, direct to angio associated with improved clinical outcome and endovascular therapy rates. So implication for this clinical practice, consideration of direct to angio as a strategy to optimize stroke workflow. Consideration for future research, need for multi-center trials to validate findings and assess generability. So this is the limitation, funding constraint. This is a single center design, and then potential impact on a study generability, learning curve. It's challenging to perform this direct to angio because we need emergency team, we need anesthesia team, and then we need a IR team. So we work in a multidisciplinary team. So we have to do a one consensus together so that we can adapt this direct to angio workflow. So early termination and potential of estimation influence on study finding and interpretation. So conclusion, direct to angio associated with improved outcome and EVT rates in large vessel occlusion stroke. Clinical relevance, potential for reducing treatment delay. We can reduce the treatment delay and improve patient outcome and call for further multi-center trials. This is the summary of this study. This is our new project here in emergency department here. This is the name. So we can see here, we share, this is the cardiac lab, and then this is our IR lab. So we are in the same place. This is our emergency department here. This is the CT scan in the emergency department. Okay. So means from emergency, from red zone, we can straight, if patient is suspected of acute ischemic stroke with the window, and then we can straight transfer here directly to our angio suite. And then we can assess there, and then we can give a IV thrombolysis here, and then if indicated, we can do directly do a thrombectomy. So just briefly, this is how we do a EVT. We have a stent retriever. This stent retriever catch the clot here, or we can do an aspiration technique, connect to the vacuum, and then or we can combine both aspiration and stent retriever technique. So this is our vacuum. We connected to this vacuum. And then this is the vacuum. We connect to the aspiration catheter, and then we suck out the clot. And then for example here, it's only take 18 minutes for this technique. Very fast. We put the catheter here and then connect to the suction vacuum, and then we can achieve a recanalization, TG3. And then stand retriever technique is also a good technique. So this is a frontal view, lateral view. We can see here, this is the marker of the stand, 3 dots, and then this is the marker of the stand retriever, and then also achieve a good recanalization. So with that, thank you. Thank you very much, everyone, for participating in this session from my team. Thank you very much, Prof. Khairul. Okay, I think we stop here. Thank you very much, and then we can proceed with other session. Thank you.